I think we shall go on to our second set of interesting cases, which is going to be manned by Dr. Madhu, who is a co-chair of UVSMI Hospitals, Bhimavaram, with a huge expertise in corneal transplant surgeries with more than 1,500 procedures done in 4 years. That's amazing, which actually is a showcase of his might. So let's hear from him.
Very good evening, ma'am. Thank you so much for giving me this great opportunity. It was a great learning experience and a lot of good talks from star worlds in the field of ocular surface. So without wasting much of time, I would like to share a modification that we have done in managing our K-Pro cases. So I have no financial disclosures. The scope of this talk would be under the following headings. So we started doing Boston type 1 keratoprosthesis basically in 2015, and we are using the Oro K-Pro that is manufactured by Orolab. And so far we have done 46 cases. And through this journey, from the inputs from the man himself, Professor Dolman, to improve our outcomes, we have started using pulsed antifungal therapy for our patients because our patients are mostly from the agricultural background. And also we are avoiding BAK-free antibiotics and frequently changing antibiotics to not develop resistance. And also on our monthly follow-ups, we have a proper contact lens hygiene and also check for microloops very meticulously, and also clean the cul-de-sacs with betadine. And most of the cases end up having a glaucoma draining device 2 or 3 years down the line. So the complications that are known with K-Pro, the most common thing is glaucoma, followed by RPMs, which are easily managed. And the next thing is the ocular surface related complications like wound leaks in the stem graft junction or in the graft host junction, infections, extrusions, and posterior segment complications. So our little modification we do will be addressing the red part of the complications here. So the importance of BCL and ocular surface protection is very, very emphasized. It's a standard of care. It prevents evaporative damage to corneal surface, and it protects the fragile ocular surface from mechanical stress, desiccation, stromal thinning, and melting. So the concept is, as we see in penetrating keratoplasty, suture materials can incite reaction knots to do so in a greater extent. And its exposed suture knots also stimulate local corneal neovascularization and inflammation. So this vascularization, which is a disadvantage in penetrating keratoplasty, was used to our advantage as an innovative technique in K-Pro for early vascularization and graft fusion. The exposed suture knots also cause foreign body sensation and irritation. This prompts the patient to seek immediate care when the bandage contact lens is lost. So this is how we retain the suture knot exposed in the 4 quadrants. And this suture knot attracts vascularization. And once this vascularization sets in, the fusion of this graft host junction happens beautifully. So with this, we have done 22 cases over the past 2.5 years in which we have seen the neovascularization has set in early, almost half of the time when we compare to our previous cases. However, there was still one extrusion because of a fungal infection. Previously, there were 2 extrusions in the 24 cases. One was because of sterile melt and fungal infections. But the most important thing is at least half of the patients came back to us when the bandage contact lens fell off because of the irritation that they had. And this prompted us to manage these cases immediately. So to conclude, the 2 advantages of this selective suture knot exposure is early vascularization leading to better fusion and lesser chances of extrusion. And whenever the contact lens is lost, the patient seeks immediate care, decreasing the chances of surface related complications. Thank you all for your kind attention.
Thank you very much. On to you, Dr. Sain, for your thoughts.
No, I think great points, Madhu. It's absolutely amazing that you're doing such great work and serving the underserved. I think there's a lot of, I mean, we can't solve all the corneal blindness with keratoplasty alone, which also you do a lot of, but in certain cases definitely need keratoprosthesis, and we need to find our own innovative ideas to improve retention and improve outcomes. So, great work.
Thank you, sir. Thank you.
Thank you very much.
Madhu, very smart innovation. Very impressive.
Thank you, sir. Thank you.